Hello, everybody. This is Barrick, and I am here with Brittany Ellett and Sierra Bronson. We are the Australia group for the HSAD 500 International Health System Analysis projects, and we are very excited to give an overview of the Australian healthcare system. So, Brittany, why don't you give us some of the background details?
Okay, so the overview of Australia's healthcare system is their universal healthcare system, where all citizens are covered by Medicare, which is funded through the taxation on their citizens. So they are treated by public hospitals and receive consultations with general practitioners and have prescription benefit packages. So about 50% of people have private insurance because it gives them more access to shorter waiting times, and they also get to choose their own doctor. The type of healthcare system they have is a federated structure where funding, delivery, and regulatory responsibilities are shared by the national and state governments. So the national and state roles are shared by the Commonwealth, which is the federal government, states and territories, jointly funding public hospitals and community care. And the Commonwealth uses its general taxation revenue to fund most of the out-of-hospital medical services and health research. So currently, taxpayers pay a Medicare levy of about 2%, and their taxable income to pay for doctors' fees, eye tests, most surgical procedures, and public hospitals. There is also a Medicare safety net set in place to put limits on the amount of out-of-pocket spending for each citizen. They are also publicly and privately driven, which, as I have stated before, they have a mix of public coverage with Medicare and private coverage through opting to get private insurance in addition to the public coverage. They also have mixed funding, which health system involves multiple funding provided by the government and individuals, health providers, and private health insurers. So some key points about the overall health is that there are more children vaccinated than in the US, which is about 93%. There is a much smaller portion of people smoking today than 20 years ago. The overall alcohol consumption has fallen in the last 50 years, and then the life expectancy is one of the highest in the world. Okay, so some figures here. The figures show life expectancy, types of housing, employment, school education, the average income per week for citizens, population and locations of people in Australia. One of the ones I want to focus on is the life expectancy of boys and girls. So a boy born between 2012 and 2014 could expect to live to be about 80 years old, and then a girl could expect to live about 83 years. And this has grown drastically since the 1980s.
So this is the framework that the Australian government uses to evaluate and analyze their health system. And we felt that it was well designed and that it was the most appropriate framework to compare our topics against. So as mentioned previously, Medicare is Australia's universal healthcare system, and people can use it to access hospitals for free and utilize other medical services at a subsidized rate. And so part of the Medicare setup is that the fee-for-service model is incorporated. So the way in which Australia's Medicare system pays out for claims is based off a set predetermined schedule that dictates the pricing for certain services. Now, this isn't to say that Australians all use Medicare as their sole choice of coverage. However, some choose to purchase private insurance as a means of having more options. For instance, through private insurance, you have the ability to select your provider and seek out alternative types of care, such as acupuncture or physical therapy, or even nursing, just to name a few. And this type of setup plays into the quality of care consumers receive. Being able to have more control over where they receive health services also means that they have the freedom to elect to go somewhere that has better health outcomes. Now moving on to comparing the quality of care versus cost of care to the framework we outlined. For the determinants piece of this framework, health behaviors and socioeconomic factors influence if someone utilizes Medicare versus private insurance, which also ties into the health and well-being aspect of the framework. Health outcomes are a component of both types of coverage, whether that be through treatment interventions or from a more preventive approach. And for the resources portion, financial, research, education, monitoring, and technology are all integral components.
Thank you, Sarah. So I think a very interesting difference between the US and Australia appears to be the wider adoption of HMOs in the US versus Australia. Do you think incorporating and managed care systems would be an improvement over the current fee-for-service billing seen throughout Australia?
So I don't want to speak to the US system too much, but just as an overview and to reiterate your point, HMOs or health maintenance organizations are very common in the US. And in the state of Washington alone, it's very common to see employers pair a more cost-effective HMO plan alongside a richer, more traditional PPO type plan. So from a cost perspective, it makes sense to utilize this model wherever savings are to be had, Australia included. However, the fact of the matter is Australia's private health insurance is community rated, meaning the cost of a premium does not fluctuate based off the demographic of a population like it does in the US. And this is just a way for their insurance to be more fair. But with that said, part of the reason HMOs are so popular is because they contain costs by rating appropriately to the population that belong to them. But with universal coverage, healthy people don't have as much of a reason to belong to an HMO. And so therefore, the subset of the population that's left interested in private insurance might result in adverse pooling, which would then in turn take away the financial incentive of the HMO that it's designed to be for.
Fantastic. Thank you, Sierra. That's a very insightful answer. Now, I think moving on, Brittany, you were going to talk about a really interesting service that's unique to Australia.
Yes, so improving quality of health in rural areas through the RFDS, which is Royal Flying Doctors Services. So there are many health inequalities in the rural areas within Australia. So that's why Royal Flying Doctors Services was established. And it was established by Reverend John Flynn, who witnessed the daily struggle of pioneers living in remote areas. So their mission is to provide excellent services in aeromedical and primary health care across Australia. A couple of their services is the 24-hour emergency evacuation services, dental care, eye care, patient road transportation, also health telehealth consultations to help with the rural and remote areas. There are approximately 23 bases, which are clinically based throughout Australia. Their funding streams rely heavily on donations, but they also receive funding from insurances, support from the Commonwealth, state, and territory governments, and support with service contracts. Also heavily based with volunteers and fundraising bequests, and are partnered up with large corporations. They're also seen as a not-for-profit organization, and they have about 4 different types of planes that cover specific areas throughout the country. And then as of 2018, we'll soon have jet airlines as well. So they have medical chests, which are for remote areas that are filled with medical supplies and drugs, which are provided under a program funded by the Commonwealth government. The Royal Flying Doctor Services utilizes the framework that we previously talked about with the intervention piece, as they provide preventative care and treatment to people in remote places. So this service is innovative and helps fill the gap for accessing healthcare services. And this is important because half of the population in Australia live in remote area and are limited to healthcare workers.
Thanks, Brittany. I think this is such an interesting service and so unique to the country. I was wondering, after having done your research on it, if you thought that there might be a role for a similar type of system in the United States.
Yes, I do. It would especially help in rural areas throughout our country, and even in low-income areas as well, because these areas are limited in the amount of healthcare workers and physicians available to treat people, especially in emergency situations. So the RFDS would become a beneficial service to them. Also, the RDF not only is operational by air, but they also have bases that have clinics which function like primary care facilities. So that would help in those areas as well that are lacking those services. And they also have eye and dental care, which can also help in that aspect as well. Lastly, it could potentially lower the overall cost the government is having to pay into healthcare because people would utilize these services before relying on emergency departments.
Perfect. Thank you, Brittany. That's good stuff. And again, so moving on. So I think we're all very impressed with Australia's healthcare system, but with any system, there are issues. And I think one of the biggest issues that we came across were the health outcomes in the Indigenous populations in Australia. So specifically, the Indigenous people that we're referring to are both the Aborigines as well as the Torres Strait Islanders. Demographically, they compose about 2.8% of the population. And in terms of actual health outcomes, just to give the objective data that we do have, cardiovascular outcomes in particular are pretty disproportionately negative in this population. For instance, in new cases of heart failure diagnosis, they represent 5.8%, while again only representing 2.8% of the total population. They're also twice as likely to die from heart failure within the first year of diagnosis. Other medical outcomes include worse control of diabetes. The average A1C is 9%, which is about 2% worse than the rest of the population. 50% of the Indigenous peoples have a diagnosis of hypertension, and there is an inequality in terms of mental health outcomes as well. I think one of the things that stands out most of all is that these diseases tend to impact these populations at a much younger age than the rest of Australia. Now, looking through the framework, there are multiple causes and contributing factors to these outcomes. Cultural aspects are significant. There's a distrust of standard Western medicine, as well as our approach to research, and the nomadic cultural roots do not play or dovetail well with our ambulatory care models that are used in Australia. Behavioral factors in terms of risk factors such as tobacco use, alcohol use, and other substance abuse are systematically higher as well. In terms of health and well-being, again, we looked at the cardiovascular outcomes, as I kind of discussed, and again, across the board, the data that is available is pretty much universally worse than the rest of the Australian population. So a much higher burden of disease and more comorbidities as well. In terms of interventions, the biggest issue really is with the outpatient or ambulatory care aspect of medicine. Inpatient acute care is relatively equivalent to the rest of the population, but there are significant problems in terms of medical infrastructure. A lot of this population is in remote locations, and the transitions of care, again, from the inpatient setting to outpatient setting have been shown to be an issue as well. Additional resources that are lacking are an ability to monitor and surveillance data of these outcomes. Again, I looked through a good number of papers and meta-analyses, and there's pretty low quality data available. So while we know the outcomes are worse, we don't have a lot of information beyond that currently. In terms of improvements that we can make, I think the biggest interventions really have to be made at a community or a systems level. And what we really need to look at doing is improving Australia, I keep saying we, but Australia, they need to improve the infrastructure that's available for their patients, especially in the remote locations. They need to begin screening more aggressively in an earlier age, especially for cardiovascular diseases. And they really need to integrate more culturally sensitive approaches that recognize the different perspectives that Indigenous people bring to the table and how that influences their healthcare.
Thanks for that, Clee. I know you touched on the determinants of health a bit, but aside from access to care, what are some of the other contributing factors to health disparities among the Aboriginal communities in Australia? Are there any other barriers outside of what you've discussed here?
Well, I think there's a lot of big barriers that come back to the cultural differences, and I think that's one of the biggest factors here. There's communication issues as well. Diverse languages. There's over 600 different dialects and languages within the Aboriginal population in Australia. And again, going back to that nomadic route, so there's 40,000 years of a nomadic lifestyle, and that does not mesh well with the whole practice of, hey, come back to this specific clinic in a few weeks. Repeatedly, that longitudinal care just doesn't fit that lifestyle very well. There's a distrust of the systems, randomization for data purposes. It's considered the height of data quality in Western medicine. Well, it's considered unethical by the indigenous people here in Australia. So there has to be a lot of work on kind of crossing that cultural divide, I think, if they want to make significant dents in these outcomes.
Great,
so
thank you.
Yeah, absolutely. And just to wrap up here, so I think overall, we were very impressed with Australia's medical system. It's definitely more organized. It provides its citizens with universal access at a much lower cost than they have in the United States. Life expectancies and other outcomes are excellent. And again, the cost is much lower. So it's a more organized system. It's a more unified system. We wondered a little bit about the fee-for-service aspects, but overall, that's a small problem. I think we were all impressed with the flying doctors, Royal Flying Doctors, and the use of that system to reach these isolated patients. And again, as I mentioned, the outcomes with the Aborigines are definitely an issue. And I'm hopeful that Australia will make strides on that in the ensuing years. A few areas where the U.S. healthcare system may be a little bit better are, the funding for research, as well as just education and training of healthcare providers. And technology may be a little bit better, but overall, I think we were very impressed. And I'll leave it open to Brittany and Sierra if you guys have any parting shots at all.
I think that about covers it.
Yep, I think that about wraps it up.
All right, and then we'll just run through references here, and we appreciate everybody's time and attention, and we look forward to discussion, and hope everybody has a great day.